is going to be for all of us. Once you complete your graduation or a post-graduation, say lecturer job, you go to any research center, start doing research and do so. But situation was not like that way back some 1988 only. Then I had to keep on searching the jobs, and finally I got into accidentally this particular field, which is assisted reproductive technology. It is really great pleasure for me to be with you people and sharing what exactly is happening in assisted reproductive technology. Let me tell you, no, so you can see because specifically I put this MSc in zoology 1990 batch from Mysore University, which is almost 100-year-old university now. I am privileged to do my MSc in zoology. If I want to say something about assisted reproductive technology in India, because it is it is worth saying it actually. The person who has done MSc in zoology and a PhD is the one who got this particular project in India, who is ICMR in charge, and he worked in AIMS, which is Delhi, and he was a director for reproductive institute, which was there in Mumbai. TC Anandakumar, Professor TC Anandakumar, who has done his PhD in Rajasthan, that is the Jodhpur University. Then after that, he got into this particular field, and he is the one man behind actually to bring assisted reproductive technology project in India and make sure that it is going to be commercialized, and infertile couple is going to get benefited in this particular field. I am accidentally got into this field after completing my MSc, doing 1 or 2 years of research work. Then I have realized what is exactly in this particular field. I had to continue because I did not get a lecturer job or whatever it is in the research field actually, and it has a really good profession which I am enjoying. At the end, you will really able to understand actually the person who is from the life science getting into the medical field, and what is the job opportunity, okay, was there, and what is the job opportunity now, what is the technology, how a life science guy or embryologist plays a very important role in the field of assisted reproductive technology. With this, no, let me get into the actual topic. uh, my topic is actually assisted reproductive technology and embryologist. Let me define what is infertility. Infertility is defined as when a female did not conceive, when there is unprotected intercourse. Uh, and there is 10 to 15% of reproductive age couples have this particular problem. 84% of conceived by 12 months of unprotected intercourse. This is because whenever we have come up with a definition, actually, we will have to come up with a standardized thing. So that's what the WHO standard says, that after you don't have a pregnancy, when you have unprotected intercourse, then you can define as an infertility. So I think this slide is explanatory. Actually, you can see that all couple, 1 in 10 couples, have infertility problem. Okay, when it comes to the age factor, 30 to 34, 1 in 7 couple. Okay, when it comes to 35 to 39 age factor, 1 in 5 couples, and when it comes to age factor 40 to 44, 1 in 4 couple. It is very clear that as the age is increased, there is an increase of an infertility rate. This is a very old, the slide which I've used it actually. You can think of yourself actually what was the lifestyle then, what is the lifestyle today. As a result, because of the social obligations, the infertility rate is really increasing. Okay, when the infertility rate is increased, there is a service is required for all these people to make sure that they are going to have their own babies. To pregnancy to take place, actually, male and female has to be there. Okay, so I am not going to go in detail of all those things. Actually, by male you are going to have a spermatozoa. These spermatozoas are produced in the testes, that is in a male reproductive system. Because I have to speak, complete my talk within 25 or 15 minutes. I'm not going to go to get into the detail aspect of it, because you are all lecturers or professors. You know what is exactly life science in the field. What is exactly spermatogenesis? Sperms are required. You know that this meiosis takes place in the germ cells, where somatic cell divide and it goes and it enters into germinal cell. This germinal cell undergoes a spermatogenesis process. At the end, you have a spermatid. This spermatid undergoes a spermiogenesis, and it is differentiated into head, neck, and midpiece, and the tail, which is very essential. Okay, to natural conception should take place, female has to produce the oocyte, male has to produce the sperm. And pregnancy should take place, there should not be any problem with a male reproductive system, female reproductive system, mainly where the tubes are to be patent, where the spermatozoa has to travel from the point of deposition, that is the vaginal area, cervix, uterine cavity, and the tubal area. Then that's the reason why we say clinically, patient tubes has to be patent. Then you have a normal conception. Otherwise, there is a problem. Coming into the morphology of the spermatozoa, it is a schematic representation. You can see head, neck, and midpiece, and the tail. The spermatozoa doesn't have a cytoplasm at all, whereas oocyte has a cytoplasm. It is mandatory that pre-embryonic development requires so much cytoplasm, which has got so many things for early embryonic development, whereas the sperm plays very important role in just delivering the paternal genome complement, which is there in the sperm head area. And you have just in the posterior part of the head centriole, which plays very important role in early cleavage, playing, getting into the mitotic apparatus, is a spindle fiber, because which is very important for early embryonic development. Oocyte doesn't have an centriole. This centriole contributed by the spermatozoa throughout the genome. I am sure I am audible. I am okay with my thing. Do I have to say no change something else, or you just have to tell me? I am
Yes, sir,
audible,
you're
no?
audible.
Audible,
Yes,
sir.
sir, you're
Audible.
audible,
It
sir.
is clear.
Audible, sir.
Okay. I'm going fast. I have to be slow. You have to tell me.
No, sir. No, sir. Everything is
Okay.
fine.
Thank you so much. Thank you so much. Okay. Coming into the semen examination, whenever the infertile couple comes to the assisted reproductive technology or IVF center, as a clinicians, those who have done medically, MBBS, post graduation in OBG, they have done a specialization course in assisted reproductive technology, where I am still teaching this fellowship student to know about embryology. They are concentrating on what exactly the semen analysis profile. Okay, uh, whatever you see on your screen is actually WHO standard. That's a recent one. WHO has got many addition. The recent one says that actually, even if you have 1.5 ml of total volume of the semen sample, that would be sufficient. Motility should be more than 50%, and in that motility, rapid progressive motility should be more than the 25%. And morphology is very important. It is say that 15% normal. Latest one say that even if you have a 4% of a normal normospermic normal morphology, That would be the sufficient. Then they say this is remained as a constant, that is
ಅದು
WBC,
ಅಪ್ಲೈ
that is
ಮಾಡೋದು
white
ಯಾವಾಗ
blood cell.
ಅದನ್ನು ಈಗ
Okay.
ಜನವರಿ
I'm getting disturbance from audience. I think speak if you mute your thing, no, you'll be able. And I'll have a separate time for the question and answer. I'll be able to answer because if anybody is unmuted from your side, it will be disturbing others. Please. Okay. I'm sure those who are in the life science and the reproductive biology, you will be able to understand what exactly it is. Female menstruation cycle generally takes place at 24 to 28 days. There are so many hormonal changes are going to takes place. If she's become pregnant, there won't be the uterine bleeding. Otherwise, uterine bleeding will be there. That is called a menstruation cycle. This itself is a big chapter and a big book, which I am not going to explain. This with the hormonal influence only, the female has this kind of the cycle, which is very important for her to prepare the bed for in case oocyte is released, spermatozoas are there, fertilization takes place, embryos form, implantation has to be takes place. Okay, so. Because so many other reasons, and that's the reason why in the very first slide I explained what is infertility. Even if you have an intercourse unprotected for an year, if you don't conceive, then only you define, because the timing of intercourse, timing of ovulation, timing of intercourse, timing of fertilization is very important. This is how the within the ovary the follicles are going to work. You can see the small, that is called the Graafian follicle. This is named after the person who is discovered this follicle. Graafian is a scientist. Okay, with the hormonal influence, it is going to increase its size gradually. Then once it reaches the stage, that is the time actually ovulation takes place. You can see from the ovary the dominant follicle which is recruited, which is developing with the influence of hormonal change, that is
ತ್ರೀ
increased
ಡೇಸ್
level.
ಮಾಡಿದ್ದೇನೆ ವಿಜಿತ್
Increased
2 days ಮಾಡಿದ್ದೆ.
level. Okay, it is released, and this is the oocyte nucleus complex will be
ಕಮಿಟಿ
picked
ಇದೆಯಲ್ಲ
up as a female part of the female
Please,
reproductive.
Sri Sai sir,
Some of the
unmute.
participants,
ಏನಂದ್ರೆ ಇಲ್ಲಿ ಯೂನಿವರ್ಸಿಟಿ ಬರ್ಲಿಕ್ಕೆ ಭಾಳ ಲೈಕ್ ಮಾಡ್ತಾರೆ
some of the participants are
Sir,
discussing,
Sri
madam.
Sai sir, unmute your.
Vishal sir, please mute your mic.
ಬಿಡ್ತಾರ ಇಲ್ಲೇ ಎಲ್ಲ ಇದು ಭದ್ರಾ ಡ್ಯಾಮು ಇದು ಇಲ್ಲೆಲ್ಲ ಸುತ್ತಮುತ್ತ ಪ್ಲಾಂಟ್ಸ್ ಅದು ಎಲ್ಲ ತೋರಿದ್ರೆ
Sir,
No, he is not aware of. He is
Sri
not
Sai sir,
listening.
unmute your.
Okay, fine. You can see this one because this is very interesting actually. As an embryologist, how sperms will be identified specifically from this oocyte. Okay, you can see 4-5 steps actually. It's always no specific, species specific. That is what would we will say. Some other spermatozoa from some other, it cannot be fertilized with the some other oocyte. Okay, that's how it is. Species. There is a sort of an understanding between the within the human actually, or the receptor. All these things will be identified. You can just see how the fertilization process takes place. Okay, this spermatozoa undergoes a physiological changes, that is called capacitation. That is the time actually acrosome is ready to digest, release their enzyme when it is comes and bind to the zona pellucida of the oocyte. Okay, hydrolytic enzyme which is there in the acrosomes will be released. It will digest the glycoprotein. Human female zona pellucida made up of a glycoprotein, which will be digested by the enzyme which is released by the acrosome. That is called, as we generally call it, as a sperm cap. Okay, once it is released, it comes in contact with the cytoplasmic membrane. That is where the specification it will identify. There are sort of the molecular biomolecular molecular thing which is takes place, I'm not a molecular biologist, which is no. I just know that it is only human, no, species specific. That's how it is got, and you can see here that's how human spermatozoa get into the oocyte of the female by a phagocytic manner. So formation or contribution of a paternal genome takes place there. So this is a picture where you can see you plenty of spermatozoa are attached to the zona pellucida of the oocyte or the egg, but human egg takes only one spermatozoa into the thing because this zona pellucida plays very important role called as the block to polyspermy. Humans has got a 46 chromosome, 23 from the egg, 23 from the spermatozoa. We know it's an haploid. These two haploid gametes fuse together by a process called syngamy, forms in a zygote that is going to develop as in a separate entity. To make you to very clear, it is a female reproductive tract where I have shown you the given the picture of 50% of the uterus, the tubal area. So this is where the fertilization takes place, where the oocyte will be waiting. Okay, after it is ovulated from the ovary, that is the time actually intercourse takes place. Sperm travels all the way from the uterine cavity to the fallopian tube and the place where the oocyte cumulus complex is there, and fertilization takes place. Thereafter, it is going to undergo division, that's called a cleavage. Fertilization zygote, it is a 2 cell stage, 4 cell stage, 8 cell stage. By the time it descends down to the uterine cavity, it will be morula or early blastocyst stage. I'm sure you are all aware of this embryonic development, in human being, because when I did my post graduation, I think we used to do with N or with the frog cross section is taken. That is what I still remember, which is very fundamental for me to understand all those things. Again, so this is what. So because fertilization is a schematic representation. Again, 1 cell, 2 cell, 4 cell, 8 cell in the blastocyst. Once it reaches the blastocyst, that is the time actually, blastocyst hatches, the gastrulation formations take place. This gastrula is attached to the endometrium cavity. That is a process called implantation. Whenever we check, if you see this last picture here, it has got a inner cell mass which is going to develop as in a fetus, tropectoderm which is going to develop as a placenta. Okay, during implantation, this is the area, placental area, tropectoderm area is the one which is going to protrude into the endometrium of the female. Implantation takes place. It releases, this tropectoderm releases HCG. When you check the blood, if you get HCG, it is very well known that today you can buy a kit in the pharma shop. You can check the pregnancy is taken through the urine. Okay, this is the HCG which is secreted by thing which is there in the blood, can be identified whether she has become pregnant or not. This is further process actually, cross section, schematic representation. Of course, this is how the gastrulations, implantation, development of the further fetus takes place. This is maybe first trimester how the fetus is developing. Okay, that is called a natural fertilization, natural conception. Coming into the causes of the infertility, causes of the infertility, plenty. Male factor, that is 25 to 40%. Both male and female factors 10%. Female factor only 40 to 50, 55%. Unexplained infertility is 10%. When I started my career as an embryologist, infertility rate was not this much what I am expecting today. Okay, you yourself, because you are all the lecturers from the life science actually, what is the change in the environment, what is the change in the lifestyle, social obligation, all these things if you can think. And if you think the ecosystem, I'm sure ecosystem was not disturbed when I start career in embryology some 30 years before. Ecosystem is disturbed now. The ecosystem has got each and every contaminant which is there in the air, which is there in the soil. Soil was fertile, soil was infertile now. Similarly, female, male. Now, I'm not blaming the female only. Those days, it was a stigma. If the female is not becoming pregnant, it is a stigma. And there was so many incidents I did not have to explain. If she is not given birth to the male baby, they were blaming the female. No, it is an awareness actually. We should be blamed for the male only, not a female, because still that stigma is there. Causes of infertility is a male factor, decreased ovarian reservoir, ovulatory disorder, tubal injury, uterine factor, systemic condition, that is infection, chronic disease, autoimmune, cervical and immunological factor, unexplained. Because each one is a big, because I am generalizing, I am just want to give you the information about all these factors. Okay, even clinical factor where MBBS or PG student who is dealing with a clinical factor, though I am aware of this clinical practice, I am not. Okay, but still, because I am a reproductive biologist, because whenever I want to do some paperwork, material, method for the research, I need to understand all these things. I'm aware of all these things. Clinical practice, I may not be aware of all these things. Coming to the treatment, you know that human female produce only one follicle, which is the dominant. Okay, if it, something changes, she can produce the two, or generally, so no, two or sometime three. These are all nature, because though there are so many 5 to 10 follicles are recruited, only one dominant follicle ovulate, sometimes two. That is the reason why you get twins and the triplet. When it comes to the artificial, assisted reproductive technology, you cannot deal with only one egg. Okay, you need to have so many eggs so that you have more chances, more embryos, so that patient is going to have a more, embryo, more chances for the pregnancy. Okay. To do all these things, actually, you have to work with our endocrine system. You will have to down regulate our pituitary, make sure that pituitary is naturally not listening to our own command, and externally we are commanding it by suppressing the pituitary. That is where gonadotropins plays very important role. Follicle stimulating hormone, and HCG is the one which we administered, and we keep monitoring by the folliculometry that will be done by the clinical side. Okay. It is not going back. I don't know why. Can you hear me?
Yeah, yes,
Yes,
sir.
sir.
Yes, sir.
Yes, sir.
Yes, sir.
Okay. I don't know, because it is not going back. Just okay. See, this is one, because no, I preserved this picture actually when I joined as an embryologist in one of the reputed IVF center in the long back. You see that laminar flow, which is a horizontal. My assistant getting into the semen analysis profile, preparation of all these things, and right side you can see before we do a procedure called intrauterine. Can you hear me now?
Yes, sir.
There is some power fluctuation actually. I don't know. That's the reason why. If you cannot hear me, just get me back, and I will be able to connect me through the hotspot. Okay. You can see the right side actually the schematic representation. It's in a preliminary procedure actually. If the male factor is fine, female factor is also fine, then tubal area is fine. We just do a procedure called intrauterine insemination. That means bypassing the vaginal and the cervix area, where you will replace the spermatozoa which is prepared. Okay. You can see this cement preparation. This is the very first technique which I learned after going through from zoology to the IVF lab. How to prepare the human semen sample? You have to process it. You can see the spermatozoa in the pellet is going to come up if you incubate in the incubator. 30 to 45 minutes you keep it. Same thing. You have to load into the catheter, which is specifically made for intrauterine insemination. Okay. Can you see? This is the female reproductive system. This is the procedure done by the clinicians. Doctor who is done a fellowship course in assisted reproductive technology, who specifically deals with this particular procedure. You are bypassing the vaginal area, cervix, and directly uterine cavities, so that the spermatozoas are not going to struggle or pass through the female reproductive tract. Okay, when it comes to in vitro fertilization, whenever we do, this is where actually our IVF embryologist role is going to come in. This is not happening naturally in female. Okay, that is the time actually we are recruiting this particular patient for assisted reproductive technology, wherein we will be aspirating the follicles from the oocyte cumulus complex from the follicles, and these oocyte sperms are dealt in the IVF lab, that is the in vitro fertilization lab, which is very expensive. Okay, where in you have to create a good environment, good uterine environment, and prepare the embryos and transfer it. So this is where I just want to explain. Uh, uh, it was actually history is very important. You cannot forget the history. Okay, reproductive biology started long back actually, and through that only, through the basic only, we were able to achieve this particular thing. Actually, late 1970 only first IVF clinic. This thing was done actually in the Cambridge, UK, and the first fellow who succeeded in this particular field is Robert G. Edward. He was basically physiologist and a genetics. Patrick Steptoe is a medical professional. Along with that, you need to have somebody who is going to help her out in the OT and other areas. Jean Prudy is a nurse. Okay. Whenever you are going to create all these things, actually you need to get into the idea of how the follicles are developing, or what is the ovary, what needs to be done, how it has to be monitored. If you are going to get more than one oocyte, what is the protocol? Therein you have to use a gonadotropin, all these things, assessment of our blood, what is the level of E2 level, all these things has to be done. So this history was done in 1978, where first test tube baby is born and it has been reported. You can see that Louise Brown with her mother, and she has become elder. She's become adult. She's even become a mother also, because many a times whenever the patient come to IVF clinic, they think that if the baby is born out of this technology, will there be a difference? No, nothing different at all. So this is our achievement in our the thing actually, where we will be able to assist infertile couple, make sure that their dream come true. These are all the various procedure which we do: in vitro fertilization, intracytoplasmic sperm injection, gamete intrafallopian tube, GIFT, and CPA. These are all the things which we have been doing. Now we do IVF and ICSI procedure only. Why it is called test tube baby? When they invented this one, actually, initially fertilization was carried out in the test tube. That is the reason why this is termed as the test tube baby. Coming to the component, what are the component when you are doing this particular procedure? Patient selection, how you are going to do the control ovarian stimulation, hyperstimulation. This has to be monitored transvaginal ultrasonography. You have to check a E2 level, and no, oocyte maturation can be carried out by administering a human chorionic gonadotropin, and oocyte retrieval, fertilization. These are all the things which is done by the embryologist in an IVF center. I'm sure wherever you are, actually, embryologist plays very important role in assisted reproductive technology. It is known that 80% of the work will be done by the embryologist, only 20% by the clinicians. Okay, whenever you are tend to get a more number of eggs, you have to superovulate the oocyte. I have told you in the beginning of my talk, only one dominant follicle will develop. By controlling a pituitary, taking control of endocrine in your hand, you will be able to make sure that you are going to get more and more eggs. Okay, so gonadotropin releasing hormone, you need to be aware of it. You have to human menopausal gonad. So now, any gonadotropin which we prepare, actually, which is actually human menopausal urine, from there you will going to get. But now you are going to get purified follicle stimulating hormone, and even a recombinant, not from the menopausal woman. Okay, this is the picture to just to explain how the stimulation protocol is monitored, which is very important. You can see in the right down how our endometrium is developing. When you are very good with the stimulation protocol, you will be able to see the endometrium, which is a triple line. After that, you have to give her a progesterone. The progesteronization take place, and that is the time, actually, the endometrium is ready for the implantation. This is the ovary picture. Generally, PCOS, polycystic ovary patients tend to be very sensitive for the FSH, that the follicle stimulating hormone, and there will be multiple oocyte. It's challenging for the clinicians to monitor all the things, make sure that she is mildly stimulated. This is a picture of womb pickup area where you have ultrasonography to see this. This is a schematic representing how you are getting into the dominant follicle with the needle, with the suction. You aspirate the follicular fluid. This goes to the embryology lab where embryologists screen the follicular fluid, identify oocyte cumulus complex. Okay, so this is another picture where follicular fluid is aspirated through the ultrasound guided, and see how the fluid are getting collected into the thing. This is the laminar flow. This is my old picture where I used to do follicular fluid screening. Right side, you can see this intracytoplasmic sperm injection. This is a micromanipulation unit where you need to look through the binocular microscope, see the egg, and immobilize the spermatozoa, put the spermatozoa into the egg, which I'm going to show at the later of my talk. This is the incubator. This is nothing but female uterus, where you maintain a 37-degree temperature, pH of 7.4, which by culturing the embryo within the culture medium, 5% of CO2 is must. This is ICSI, intracytoplasmic sperm injection, which is meant for male infertile patient, where sperm count is very less, where you will be able to pick up one sperm, inject into the oocyte. You can see this is a human oocyte cumulus complex, female oocyte. This is the proper circular, is it proper oocyte. Surrounding that, you have a granulosa cells. This is how a mature oocyte looks. See, this is another picture. Whenever we perform intracytoplasmic sperm injection, you can say in the previous picture, granulosa cells were there surrounding the oocyte. You can see the oocyte with the first polar body. This is the human oocyte, female oocyte. This is how the oocyte has to look whenever you are performing the ICSI. So this is another picture where how you are going to isolate the gamete from the male and female, do the in vitro fertilization in the dish, and develop the embryo transfer back into the uterus. You can see this is the actual picture. Okay, spermatozoa swimming around, oocyte cumulus complex is there. This is a conventional IVF. I am not taking the sperm and injecting the single sperm into the egg. Okay, it is uh, uh, the sperm which is naturally selected from the egg. This is called in vitro fertilization. You can see this is a zygote. You can see here there are two polar bodies are there in the 12 o'clock to 1 o'clock position, and two structure, circular structure. That is the specification. That is the confirmation for the fertilization. One nucleus from the paternal side, one nucleus from the maternal side. This is again schematic representation. Whenever you grow the embryo, how these embryos are going to be there: 2 cell, 4 cell, 8 cell. And you remember, initially the embryo depends on the maternal genome. Gradually, when it reaches to the no, 8 cell stage, that is the time actually entire genome, embryonic genome activity gets activated. From there, it is independent. This is the 8 cell stage embryo. Whenever we perform the IVF procedure in the IVF lab, we do embryo transfer 4 cell stage and 8 cell stage. I'm sure if you are from the life science, if you are dealing with the reproductive biology, these cells are totally potent. Even if you take one cell separately, it can develop into the embryo. This is the last stage of embryo where an embryologist take care of in IVF lab, blastocyst stage. Before it hatches or during the hatching, this is the time this has to get into the female reproductive time for the process of implantation. And as an embryologist, when you are performing the procedure actually in IVF lab, you have to grade quality of the oocyte, quality of the zygote, quality of the embryo, and the blastocyst. These are all quality is depends on the quality of the oocyte we start with, which you are going to get. Once you grow the embryos, you can see again it is a picture where a clinician, after embryologist load this gamete into the embryo transfer catheter, clinicians load into this catheter, and it will be delivered into the uterine cavity, and thereafter you will have to see how the fertilization process. This is one picture. You can see the left side. It is a procedure performed by the embryologist in fertile male, actually, where you have to pick up the in the red circle. You have injecting pipette. Actually, there is a small sperm which is going to get into the cytoplasm. Generally, naturally, spermatozoa pass through the zona pellucida, natural fertilization. Wherever male infertility is there, oligoasthenospermic, spermatozoa are not there in the seminal plasma. You have to retrieve the sperm from the testes. These sperms will be put by the embryologist using a micromanipulator directly into the oocyte. One sperm, one egg. This is the norm of the fertilization. You can see in the sperm which is a motile there. You have to immobilize with a micromanipulation unit. Then take this sperm into the pipette. This pipette has to get into this the thing, the oocyte. We can see actually whenever you are doing this intracytoplasmic sperm injection, you are not supposed to disturb the cytoskeleton of this oocyte. Then you will be able to have a good embryogenesis. You can see that, okay. this is a human female oocyte. Actually, you have to orient the oocyte in such a way that polar body is either in the 12 o'clock position or in the 6 o'clock position, so that mitotic apparatus, that is spindle fiber, is not going to be get disturbed. If it is get disturbed, that means there is a problem with the embryogenesis. You can check this one. This is the holding pipette. You have to look through this inverted microscope. It has to be performed. Oocyte measures about 120 micrometer. Okay. The sperm measures about 3 to 4 micrometer. You can see how the sperm is immobilized. You have to have a control, which is very important. It is very advanced technology wherein you have to pass through the cytoplasmic membrane. You see, make sure that you are there in the cytoplasm by aspirating it, then release the sperm into that. Okay, so this is become as in a boon for a male reproductive system. Otherwise, those days, we used to counsel the patient to go for a donor insemination of human semen sample. This is called, what you have observed is an XC. Okay, and you see here, this is another picture actually, and in this actually it is used in a poloscope where you will be able to see whether mitotic apparatus is away from the injecting point. And this is another advanced technology where you will be able to grow the embryo up to the blastocyst stage. And it is known that by growing the embryo up to the blastocyst stage, you will have a better pregnancy stage. You see, this is a time lapse video. How this, from the time of the insemination, how the sperm get into that, fertilization takes place, how is the polar body's two cell stage and the four cell stage. Like this, you will be able to monitor without disturbing the embryo. Even if you have an app in your mobile, without disturbing the incubator, you will, without disturbing the embryo, you will be able to check in your mobile and grade this embryo, select for the embryo transfer. This is assisted. You can see the right side extreme top, 8 cell stage in the zona pellucida. Many a times, what happened when the embryos develop up to the blastocyst stage, okay, it may not be able to come out from the, I would say the zona pellucida or a cocoon kind of a thing. In that cases, with using the laser, you will be able to make a hole in that, so that embryo will be able to come. There are different techniques, mechanical techniques, chemical techniques, and the laser is the one which is the latest. If you can see this right side, if you can see the embryo is held by the holding pipette, you can see the three holes actually through which the embryo, when reaches up to the blastocyst stage, it can come out. And crab preservation, whenever you create a more embryo, you are, according to our the ART rule, you can transfer only two, maximum three. Rest of the embryos has to be crab preserved. We have a very well defined vitrification crab preservation system, wherein in case the patient did not become pregnancy in the first transfer, then you can utilize the crab preserved embryo, thaw it again, you prepare a patient and do the transfer. This is represented. This is almost minus 180 degrees centigrade. Embryo will be crab preserved. Nothing will happen. This is an example for the cryo tank. And this is another one which is advanced technology, pre-implantation genetic screening. Whenever we perform the IVF procedures, embryos are generated in vitro. There are some factors which may be a problematic for as far as genetic complement is concerned. This is one department wherein we will remove the 8 cell stage, one or two blastomere or a tropectoderm, send it to genetics lab, get the information about genetic complement, then we decide which embryo is euploidic, which embryo is aneuploidic. Euploidic embryos are considered for the transfer. Okay, you can see this how embryo biopsy is carried out. This is a blastocyst stage actually. What you can see is the inner cell mass. Red spot is actually the laser. Using this laser, we will be able to remove this, make the hole there in the zona pellucida area. When we create a hole, you can see this tropectoderm is protruding out. Okay, and it is known that initially we used to do 8 cell biopsy, and number of cells were less. You can see this tropectoderm area. We have created a hole there. It's a embryo biopsy needle is there. This is performed through the inverted microscope. Some of the tropectoderm cells are sucked into the biopsy needle. Okay, you see here it will be pulled. You have to create a pressure, pull it. We creating a pressure. We have a laser point there. No, it is like a video game kind of a thing. With a foot you will have to click it, and it will be able to hit the area. See, some of the cells is removed, so that will be sent for by genetic lab. You get the information. If it is a euploidic, we transfer it. And I think this surrogacy part is not going to be too much. This is called a third party reproduction when you don't have chances of pregnancy to carry for your own actually, or some sperm factors are problem. You have to go for a donor egg program, donor sperm. If there are some female doesn't a congenital problem will be there as far as uterus. In such cases, they have to go for surrogacy, wherein oocyte and the sperm from the same couple, but only the fetus is going to develop from this. So that is called surrogacy, because there is so much strict criteria is there. You'll have to follow this criteria. I myself is one of the board member actually before, because any technique you have in the health sector, it cannot be misused. That's the reason why the guideline is very strict. You will have to follow all these criteria, then you will be able to get into that. Okay, this is all about the procedure which we have explained what is happening to our assisted reproduction. Coming into the actual embryologist thing, actually this picture is very clear. I am a zoology student. I did my PG, was searching for a job. I did not become a lecturer. Did not become a reader or a professor in the field of life science to teach in the any university. Rather, I moved out, become an embryologist, and I'm very glad to tell you the place where I did my post graduation. I was successful to start an embryology college, which is called International Institute of Assisted Reproductive Technology and Research Center, which is affiliated to Mysore. Even when I started my college, Shakuntala was also one of the visiting professor over there, teaching, giving information about the fundamentals of reproductive biology, basics of reproductive biology. I am almost 7 years actually. Fifth batch is going on. I wanted to give it back to this particular field, and my students are there and they are learning. They are getting into the IVF center all over India, and they are also moving abroad because the chances are there. Now, after this ART rule has come, those who have done clinical embryology for 2 years, regular course, not a distance or whatever it is, they will be eligible to practice as an embryologist in the assisted reproductive technology in the IVF field. Because I come from this particular field, this is a campus kind of a thing. It is there in the Mysore. Okay, you can see this. This is one page actually which I preserved. It is in 2001 to have an guideline for those who are practicing IVF. with the Indian Staff Science Assistant and Dr. T.C. Anand Kumar. He just conducted in a workshop where we all sat together, and we have come to conclusion that there must be a guideline so that free and fair practice has to be done. I was very happy to associate it with that particular team. You can see in this picture, my name is there. This is the picture which I have got. My IVF lab is like this only, but I have discussed with my other colleagues. Actually, I want to give it to 100%. I want to have in a lab which is a state of art, so that the student will be get benefited all these things. Like in hospital, whatever the IVF lab, same thing is replicated over, so that the students who are joined here actually they will feel that in the real environment. There is the classroom, there is a modular IVF lab, all department, andrology, IVF lab, ICSI, vitrification, all these things are placed in, so that they learn here. After completing their course, third semester only, there is a chance for all these things. The company people are coming, then campus selection is there. They are doing an embryologist profession. This is one picture I always put it. I'm very glad to be associated. 1963, Enagamachi is the one who is done IVF with mice. Same idea is taken up with the Edward, who is the reported the first test tube baby in 1978. With him, Dr. Bavister is the one who is worked as a postdoctoral fellowship. I am very opportunistic to be associated with Dr. P.B. Sheshgiri, who is in term was worked with a barrister. He started working in Indian Staff Science in Bangalore, worked with the animal model. My friend Dr. Mukesh Kumar and me were associated with particular thing. I was, really, happy to say that I am getting got associated with. Nobel laureate who is reported the first IVF test tube baby. This is a picture when I started career in 1993 after not getting any lecturer job anywhere. Accidentally got into that. I went to Delhi where the AIMS the conference was there when I was working in Indian Staff Science. I happened to meet with discuss with. This great legend who is a pioneer in a study to